Hello, everyone. In the next few minutes, I will talk about dosing of monoclonal antibodies in pediatric patients and the underlying rationale for the used dosing approaches. Over the past decades, much knowledge has been gained on the impact of childhood development on the disposition mechanisms of small molecule drugs, as exemplified here for drug metabolizing enzymes as well as drug transporters. Unfortunately, large therapeutic proteins like monoclonal antibodies follow different disposition mechanisms, and not much knowledge has yet been gained about the impact of childhood development on these pathways. So the major elimination pathways for therapeutic proteins, including monoclonal antibodies, is non-specific proteolytic degradation. And this ultimately uses the same catabolic pathways as endogenous or dietetic proteins that are ultimately resulting in amino acids that are reutilized in the endogenous amino acid pool. The major sites for proteolysis are different from classic drug metabolism and excretion organs. Major sites of proteolytic protein degradation are the gastrointestinal tract, the skin, the muscle tissue, and the reticuloendothelial system. Especially endothelial cells that line blood vessels are the major contributor of endocytosis and subsequent lysosomal degradation. And that's simply because of the large surface area that these endothelial cells have in relation to the major distribution space, the vascular space for monoclonal antibodies. So that means those organs and tissues that have large capillary beds, and by that many endothelial cells, are the major contributors to elimination of therapeutic proteins. In this case, skin, intestine, and muscle. Also important contributors are phagocytic cells of the reticuloendothelial system, so macrophages, monocytes, Kupffer cells, Langerhans cells, wherever they are located within the body and have major phagocytic activity. Minor sites of degradation are liver, kidney, spleen, and lungs. Now, the overall prerequisite for proteolytic degradation is uptake into the intracellular space. This can either be facilitated by a passive process called pinocytosis, which is ultimately a fluid phase endocytosis, but it can also be more efficiently mediated by either relatively unspecific promiscuous membrane receptors like the LDL receptor or sugar recognizing receptors, or by interacting with membrane standing targets for the monoclonal antibody, which then result in so-called target-mediated endocytosis. In addition to this general proteolytic degradation pathway that is the major contributor for the elimination and the clearance of monoclonal antibodies, there are several other processes that can have relevance. For example, pre-systemic degradation, if these monoclonal antibodies are not given by intravenous injection, but by subcutaneous administration. There's the proteolytic degradation that we talked about. There is a recycling process, a salvage pathway that basically counteracts the proteolytic degradation through the neonatal FC receptor or FcRn. And this recycling process can be influenced by a variety of different factors. We'll talk about that in a few minutes. But then there are also two other major contributors. One is so-called target-mediated drug disposition. That would be the binding of the monoclonal antibody to its target. That can either be a soluble target or membrane standing receptor. Those, again, have their own turnover kinetics as symbolized here. And ultimately, this results in the formation of a drug target complex, so a complex between the monoclonal antibody and its membrane standing receptor, for example. Now, this complex can be internalized and can be degraded. So it's not only related to the drug effect, but it also is an additional elimination pathway. In addition, many therapeutic proteins trigger immune reactions in the body, the formation of so-called anti-drug antibodies or ADA. And those ADAs, here again symbolized with turnover kinetics, can ultimately form immune complexes, and those immune complexes can also be degraded in the body through the general degradation pathways for immune complexes, which ultimately then constitutes an additional elimination pathway for the monoclonal antibody. So when we look at the mechanistic differences in processes for monoclonal antibodies that affect pharmacokinetics between adults and pediatric patients, then there is some knowledge available. It's still emerging, but we have in some areas, we already have some understanding of what might be different. So if we start in the upper left corner with an antibody that's given by the subcutaneous route, then these antibodies are in the subcutaneous space, are preferentially taken up into the lymphatic system rather than the vascular space after subcutaneous or intramuscular administration. So the route in pediatrics, the route of administration is still the same preference as in adults, where subcutaneous is preferred to intramuscular simply based on patient convenience, as well as on the lack of the need of a healthcare environment to ultimately administer it, if it can be self-administered at home by subcutaneous administration. Now, in younger pediatric patients, sometimes intramuscular administration is preferred compared to subcutaneous, simply due to ease of injection to the muscle or to the vastus lateralis of the thigh. Now, what has been observed is that there's an increased rate of absorption after subcutaneous or intramuscular administration in young pediatric patients compared to older children and adults. And the reason for that is simply the increased extracellular fluid volume in young pediatric patients that is well established, but also, and probably more importantly, the higher perfusion rate through plasma as well as the lymphatic system. And as I mentioned before, large therapeutic proteins like monoclonal antibodies after subcutaneous administration are preferentially taken up into the lymphatic system. And even though the lymph flow is slow, it's only 0.2% of the plasma flow rate, it seems to be much higher in young pediatric patients compared to adults. And that would result in a faster absorption process. For palivizumab, a monoclonal antibody against RSV that's used in young pediatric patients, a 3 times faster absorption rate had been observed in pediatric patients compared to adults, with no difference in the extent of absorption. Now, when we now focus on the right side on drug distribution, then large therapeutic proteins like monoclonal antibodies distribute largely by convective extravasation from the vascular space into the interstitial space and then drainage into the lymphatic system again. Now, as I already mentioned, there's a well-known difference in tissue water content of newborns and infants relative to older children and adults, and the fraction of total body volume available for distribution is thus expected to be higher in children for hydrophilic macromolecules, such as monoclonal antibodies. In addition, infants seem to have larger capillary beds and thus a larger capillary surface area per tissue volume, and they also seem to have a larger proportion of leaky organs and tissues, so liver, kidneys, and spleen, relative to body size. And based on these two things together, one would expect that extravasation is faster and the concentration differences between vascular and extravascular drug concentration are lower in newborns and infants compared to older children and adults. When we look at the elimination processes, we already mentioned the unspecific proteolytic degradation and then the FcRn recycling process, as shown here on the bottom in the middle. If we look at FcRn, then FcRn, of course, is a recycling process for immune globulins within the body, not only therapeutically administered IgG molecules, but also IgG molecules that are endogenously available. And what is well known is that children have much lower reference values of immunoglobulin G molecules compared to adults. And that basically means that for the same number of FcRn molecules that can facilitate this recycling process, a much lower abundance of IgG molecules is available. And that means that you have less of a saturation process. So you would expect that in young pediatric patients, the FcRn recycling process is more efficient due to these lower endogenous IgG concentrations. So if we summarize and look at this with several other processes, lysosomal protein turnover and the efficiency of the FcRn recycling could be potential mechanisms for elimination differences between children and adults after correction for body size differences, if we consider only proteolytic, unspecific proteolytic degradation. Now, since children, and including infants, are able to maintain homeostasis of immunoglobulins, they are assumed to eliminate therapeutic proteins, especially monoclonal antibodies, with the same endosomal clearance pathways. And based on preliminary results, expression of FcRn is not substantially different between pediatric patients and adults. However, infants have, as I showed you in the previous slide, substantially lower reference values for endogenous IgG subclasses compared to older children and adults. Once residual maternal IgG has been lost, and that basically means less competition of endogenous IgG for the available FcRn recycling process, and thus a reduced clearance of the therapeutically administered monoclonal antibody would be expected. Now, working against this process is the third bullet point here, which is basically an increased general protein turnover that has been observed, especially in young pediatric patients compared to adults. So, for example, for low birth weight infants, protein metabolism has been described as 2 to 3 times faster than in adults when normalized for a kilogram of body weight. So that ultimately would mean faster non-specific proteolytic clearance, and that would mean increased clearance of a monoclonal antibody. So whether the age effects related to elimination cancel out or actually achieve clinically detectable differences in elimination of therapeutic proteins remains to be determined in future studies, and there's really only very limited data currently available that ultimately may shed some light on the age dependency or developmental dependency of these processes. In addition, there are the target-mediated elimination, as I had mentioned before, and the immune complex formation. With regard to target-mediated elimination, we really have this obviously something that's very specific for the specific target that a monoclonal antibody is designed for, and there may be differences in target abundance, target turnover rate, target affinity, or drug target internalization rate that all may potentially affect differences in clearance between pediatric patients and adults. Similarly, there's only limited knowledge so far with regard to immune complex formation in pediatric patients. Obviously, immunogenicity occurs also in pediatric patients, but whether the ADA incidence rates are much different in young pediatric patients compared to adults seems to be unclear. There are examples where there are higher incidence rates reported, but then there are also others where no difference have been detected. So what are the general considerations then for pediatric dosing? Well, dosing regimens for monoclonal antibodies in pediatric patients need to take into account differences between children and adults with regard to target exposure range, size differences, and of course, ontogeny of absorption and disposition processes relevant for monoclonal antibodies. So ultimately, pediatric dosing can be seen as a compromise between precision medicine and practicability. So it basically is a balance between sufficient granularity to account for these potential size and age-related differences and limited clinical complexity to avoid overburdening LSPEP providers and avoid medication errors. What helps a little bit in this context is that many monoclonal antibodies have high tolerability, often no defined maximum tolerated dose, and usually very limited off-target toxicity that may allow for a less precise dose selection for many monoclonals in the individual patient compared to small molecule drugs. There's also oftentimes a lack of biomarkers indicative of drug disposition processes, which we have, for example, with small molecules like creatinine clearance as indicator of renal function. So with therapeutic proteins, some things like albumin turnover have been, and albumin levels have been discussed as indicators of protein turnover, but that's still in very, very early stages. With regard to the pediatric dosing approaches that are used in practice, flat dosing is relatively rarely used. is only acceptable for monoclonal antibodies with a flat exposure response relationship. The example would be the PD-L1 inhibitor avelumab. Body weight-based dosing is not optimal due to the common nonlinearity between monoclonal antibody clearance and body weight. And allometrically adjusted dosing that takes this nonlinearity into account would theoretically be preferable, but the dose calculations based on exponential functions would ultimately be impractical in clinical use. So what are then the approach doses that are actually used? So the dosing approaches, it's a tiered fixed dosing, where one of several body weight or age-defined patient strata receive different flat doses. This is highly attractive due to its simplicity of implementation, shown here with an example for adalimumab. A more granular individualization would be a similar approach where now a tiered body weight-based dosing is given. So rather than flat doses in each strata, a body weight adjusted dose, as shown here for tocilizumab, is used. Additional approaches that have been used is a hybrid, a mixture basically between flat fixed dosing for older children or adults, and then a body weight adjusted dosing for the younger ones, as shown for etanercept. And finally, pharmacodynamic endpoint-based dosing if the pharmacodynamic endpoint is easily accessible, as it has been used for omalizumab, where IgE levels are measured, and based on the pretreatment serum IgE levels, a dosing table is used to adjust pediatric dosing. Now, with regard to pediatric dosing in infectious diseases, the extrapolation considerations, usually dose selection is based on the adult dose exposure and exposure response relationship, and usually limited experience in pediatric patients, oftentimes a stepwise approach, first using adolescents and older children, and then going to younger pediatric age groups. The tools that are used in this context are population PK/PD modeling, as well as physiologically based pharmacokinetic modeling. In a recent review by the Food and Drug Administration, it could be shown that PK/PD is the major tool that's used here in 19 out of 20 cases. The reason for that is most likely that PBPK modeling is still associated with a lot of uncertainty in young pediatric patients due to our limited knowledge in the drug disposition processes in this group of patients. So the frequent assumption for infectious diseases is that the exposure-response relationship is independent of age and maturational differences and solely determined by drug concentration and interaction with the infectious agent. And then, if that is given, exposure matching is sufficient for dose selection to result with a defined number of individuals that exceeds a given likelihood to reach a predefined exposure range. An example for that is raxibacumab. Raxibacumab is a monoclonal antibody used for the prophylaxis and treatment of inhalational anthrax exposure in children and adults. The dosing is weight-based in adults, 40 milligram per kilogram, and then in children, 3 different strata based on body weight. Now, dose selection was established here under the assumptions that drug disposition across pediatric populations from birth to 18 years of age was primarily due to developmental growth without any additional maturational processes. And then antibody binding is specific to the anthrax toxin and does not vary due to inter-individual differences in age and weight. Now, this approach has been questioned more recently, and it has been shown that while scaling of PK-based on allometry seems to be well supported for monoclonal antibodies for adolescents and children down to 1 year of age. Deviations in these predictions have repeatedly been described for younger age groups. That has, for example, been shown for palivizumab, that has been widely used in newborns and young infants. So what are my take-home messages? Monoclonal antibodies use different drug disposition and elimination pathways compared to small molecules. They are often knowledge gaps in which elimination pathways contribute to their disposition and to what extent. For most known elimination pathways for monoclonals, ontogeny information in pediatric patients is still emerging, but limited. So due to the limited understanding of these molecular and physiologic processes relevant for monoclonal antibody disposition and their autogeny, approaches used in pediatric extrapolation, such as PBPK modeling, remain challenging with oftentimes substantial uncertainties at the current time. This is underlined by the experience with palivizumab, where age-associated clearance differences could not be described by allometry alone and required consideration of additional maturational effects. And numerous approaches are used in pediatric dosing of monoclonals that strike a balance between individualization and complexity in clinical dosing. With that, I would like to close. Thank you for your attention. I have a few references in addition for those that might want to read more about dosing of monoclonal antibodies in pediatrics. Thank you.